everyone, I am Dr. Rajitha, first year resident, Radio Diagnosis, Government Medical College, Anantapur. Today I am going to discuss about CT Coronary Angiography basics. Before going to main topic, I am requesting please like, share and subscribe my channel for more such useful videos. Coming on to CT coronary angiography, coronary artery disease is the #1 leading cause of morbidity and mortality worldwide. CT coronary angiography is a non-invasive technique to detect the coronary artery disease by injecting the contrast medium into the vessels. In my topic, I am going to tell about what are all the indications, contraindications and the protocol to be used, and coronary anatomy and different types of plaques and their attenuation and grading of coronary artery stenosis, and finally about CAD-RADS. Move on to indications. CT coronary angiography has many indications, but I have mentioned very important ones here, and it is indicated in conditions like where we have to know the anatomy of the coronary arteries, and for evaluation of the patients with stable chest pain, and to know the patency of the coronary artery bypass graft or implanted coronary stents. And it is also an alternative procedure if invasive coronary angiography is not possible or it carries high risk. And it is also contraindicated in patients with acute ST elevated MI, because in such patients it delays the treatment, and patients who are unable to hold breath. CT coronary angiography is a challenging procedure in patients with acute respiratory distress, because for this procedure patient has to hold their breath for at least 10 to 12 seconds, and in patients who are allergic to iodinated contrast medium, and in patients with irregular heart rhythms like atrial fibrillation and heart blocks, in renal failure and pregnancy, patients with high coronary calcium scores such as more than 1500. In such patients, the dense plaques which limits the evaluation of the stenosis. So we will advise invasive coronary angiography in such patients. For CT coronary angiography, the protocol used is, we have to prepare the patient, take the informed consent from the patient, and patient should be well hydrated and fasting for 4 hours, and patients are instructed to hold the metformin for 24 to 48 hours to avoid metformin related lactic acidosis. And serum creatinine of the patient should be checked before the procedure. It should be less than 1.6 milligram per deciliter, and patients are also advised to take cardiac medications as usual. Patient's blood pressure, heart rate, saturation should be checked before the procedure. The patient should be pre-medicated with beta blockers if the heart rate is more than 60 to 65 beats per minute. They are given metoprolol 50 to 100 mg or ivabradine 5 mg 1 hour before the study to stabilize the heart, and nitroglycerin 0.5 mg sublingually before injecting the contrast media. Nitroglycerin will improve the coronary diameter and increases the number of accessible segments of the coronary artery for better evaluation of the coronary artery disease. And patient should be positioned in supine position with heart in the center of the gantry, and scan length is from bifurcation of the trachea to just below the diaphragm, and throughout the procedure patient's ECG should be monitored. The ECG gating may be prospective or retrospective. In prospective ECG gating, the image acquisition is done at predetermined part of the RR interval, and it is always sequential procedure, and it causes low patient dose. For prospective ECG gating, patient weight should be less than 100 kilograms, and patient should have stable sinus rhythm with heart rate less than 60 to 65 beats per minute. For retrospective ECG gating, image acquisition is done continuously throughout the RR interval, and the data from selected points within the RR interval is taken for the reconstruction of the images. In our institute, the retrospective ECG gating is doing. For contrast media, the patient should be secured with 18 gauge IV cannula in anticubital vein. The contrast medium is non-iodinated contrast media at 1.2 ml per kg body weight at the flow rate of 4 to 5 ml per second at the pressure of 325 psi. And after the injection of the contrast media, the CT scanners will acquire the data in a single breath hold. The post-processing coronary arteries are reconstructed in axial images, multiplanar reformation images, and maximum intensity projection and volume rendering techniques. Move on to coronary artery anatomy. Coronary artery is a vasa vasorum that supplies the myocardium, and the coronary artery arises just superior to the aortic valve and which supplies the heart. We can see this image showing aortic valve with its cusps. This is the right coronary cusp, this is the left coronary cusp, this is the posterior non-coronary cusp. We can see the right coronary artery arising from the right coronary cusp and left coronary artery arising from the left coronary cusp. The same we can see in CT coronary angiography. The right coronary artery arises from the right coronary sinus of Valsalva. This is the anterior projection of the heart, and this is the right anterior oblique projection showing right coronary artery and its branches. Right coronary artery arises from the right coronary sinus of Valsalva. It traverses between the right atrium and the right ventricle through the right atrioventricular groove, and it gives a branch with an acute angle is called acute marginal branch, which supplies the free margin of the right ventricle. Right coronary artery further traverses through the right atrioventricular groove and it reaches the base of the heart, and which ramifying into two large terminal branches. One is called as posterior descending artery, which further traverses in the posterior aspect in biventricular groove, and one more branch is posterolateral branch which supplies the inferior aspect of the heart. This is the right coronary artery and with its branches. In 50 to 60% of the individuals, the first branch of right coronary artery is conus branch, which supplies the right ventricular outflow tract. In 30% of the individual, conus branch arises directly from the aorta. Sinus nodal branch is the second branch of right coronary artery in 60% of the individuals. In 30% of the individual, sinus nodal branch will arise from the circumflex branch, which supplies the SCA node. Then it gives a large branch with an acute angle called as acute marginal branch, which supplies the free margin of the right ventricle. After reaching the base of the heart, it ramifying into two large branches. This is the posterior descending artery, which further traverses posteriorly in the biventricular groove, and this is the posterolateral branch which supplies the inferior aspect of the heart. This is the CT coronary angiography showing the aortic valve showing 3 coronary cusps. This is the right coronary cusp, this is the left coronary cusp, this is the posterior non-coronary sinus coronary cusp. We can see the right coronary artery arising from the right coronary sinus, which traverses between the right atrium and the right ventricle, and it giving a first branch called as conus branch, which supplies the right ventricular outflow tract, and further it traverses and gives a small second branch called as sinus nodal branch, and it traverses further between the right atrioventricular groove and gives a branch with an acute angle is called acute marginal branch, which supplies the free margin of the right ventricle, and it further traverses in the right atrioventricular groove and reaches the base of the heart, and which ramifying into 2 large terminal branches. This is the posterior descending artery, which further traverses in the biventricular groove, and this is the posterolateral branch which supplies the inferior aspect of the heart, and this is the CT volume rendered image showing right coronary artery traversing in the right atrium between the right atrium and the right ventricle in the right atrioventricular groove, and which ramifying into 2 branches. This is the posterior descending artery which traverses in the biventricular groove, and this is the posterolateral branch which supplying the inferior aspect of the heart. Move on to left coronary artery. The left main coronary artery arises from the left coronary sinus. Left main coronary artery almost immediately dividing into 2 branches, left anterior descending artery and left circumflex branch. Here we can see left main coronary artery dividing into left anterior descending artery and left circumflex branch. The left anterior descending artery supplies the interventricular septum through the septal branches, and it supplies the anterolateral part of the left ventricle through the diagonal branches. This is the first diagonal branch, this is the second diagonal branch. The first diagonal branch is the point which divides the left anterior descending artery into proximal and mid portions. There can be more than 1 diagonal branches. Then left anterior descending artery further traverses through the anterior aspect of the interventricular groove and reaches the base of the heart, and which anastomose with the posterior descending artery in the interventricular groove, and the other branch is left circumflex branch, which travels between the left atrium and the left ventricle in the left atrioventricular groove, and it gives branches with an obtuse angle. This is the first obtuse marginal branch and this is the second obtuse marginal branch. Usually left circumflex artery will terminate as marginal branches, but in individuals with left dominant heart, the left circumflex artery terminates as posterior descending artery. This is the CT coronary angiography showing left coronary artery arising from the left coronary sinus, and the left main coronary artery immediately dividing into 2 branches. This is the left anterior descending artery, this is the left circumflex artery, and in 20 to 30% of the population, the left main coronary artery ramifying into three branches. This is the left anterior descending artery, this is the left circumflex branch, and this is the ramus intermedius branch. This is the CT coronary angiography volume rendered image of the heart, showing left main coronary artery further dividing into left anterior descending artery, which traverses between the right ventricle and the left ventricle in the anterior aspect of the interventricular groove. Here we can see this is the first diagonal branch, this is the second diagonal branch, with supplying the anterolateral aspect of the left ventricle, and it gives small septal branches which supplies the septum of the heart, septal portion of the left ventricle, and this is the ramus intermedius branch. In this axial image we can see left main coronary artery giving a branch is called left anterior descending artery. This is first diagonal branch. These are the small septal branches with supplying the septal portion of the left ventricle. In this image, left circumflex artery is not visualized. This is the volume rendered image of CT coronary angiography showing left main coronary artery arising from the left coronary sinus and which ramifying into three branches. This is the left anterior descending branch, and this is the left circumflex branch. This is the left circumflex branch which traversing between the left atrium and the left ventricle, and this is the first obtuse marginal branch, and this is the second obtuse marginal branch, and this is the ramus intermedius branch. Coming on to dominance of the heart. The dominance of the heart can be defined by a vessel which gives rise to posterior descending artery. 80 to 85% of the individuals are with individuals have right dominance. It is defined as when the PDA is supplied by the right coronary artery, then it is called as right dominance, and when PDA is supplied by the left circumflex branch, then it is called as left dominance. The codominance is when the only PDA is supplied by the right coronary artery and the circumflex inferior artery and circumflex posterior artery supplied by the left circumflex branch, then it is called as codominance. Move on to types of plaques. In CT coronary angiography, we will see three types of plaques. These are non-calcified plaques, and mixed coronary plaques are partially calcified plaques, and calcified plaques. We can see this is the plaque with no calcification, this is the plaque with partial calcification, this is completely calcified plaque, and the intra-plaque calcification destabilizes the plaque and causes plaque rupture. Plaques may be of two types: stable plaques and unstable plaques. Stable plaques have large calcifications with smaller lipid pools with fibrotic tissue, and high risk plaques or unstable plaques have spotty calcifications with central necrotic core with proliferation of the vasa vasorum and the large necrotic core covered by thin cap fibroathiroma. The features of vulnerable plaques are low attenuation plaques and positive remodeling, spotty calcifications, and napkin ring sign. Low attenuation plaques are the plaque with less than 30 Hounsfield units on CT coronary angiography is called as low attenuation plaque. The positive remodeling is when the plaque causing compensatory when the plaque is causing the compensatory outward enlargement of the vessel wall at the site of the atherosclerotic lesion without significant luminal stenosis, then it is called as positive remodeling. This is the soft plaque causing outward enlargement of the vessel wall without causing significant luminal stenosis. The positive remodeling is more frequently seen in patients with acute coronary syndromes when compared to stable angina. Spotty calcifications are when the plaque with calcifications less than 3 mm is called as spotty calcifications. The spotty calcifications on CT coronary angiography are associated with high risk plaques. Napkin ring sign. Napkin ring sign is a qualitative high risk plaque feature on CT coronary angiography. It is defined as a central low attenuation area adjacent to the coronary lumen, which is surrounded by a ring-like high attenuation tissue, is called as napkin ring sign. This is the necrotic core. It is the ring-like fibrous plaque. The NPS is strongly associated with major adverse cardiovascular events. This is the representative image of plaque characteristics which are identifiable on CT coronary angiography. Based on the plaque composition, plaque may be non-calcified plaques and partially calcified plaques and calcified plaques. High risk plaques are low attenuation plaques and spotty calcifications and positive remodeling and napkin ring sign. Based on the attenuation pattern, plaques are heterogeneous plaques or homogeneous plaques. Move on to grading. The coronary artery disease is graded based on the percentage of the stenosis into no plaque and no stenosis. This is called as normal coronary arteries, and this is the minimal coronary artery disease, mild coronary artery disease, moderate coronary artery disease, and severe coronary artery disease. CAD-RADS is coronary artery disease reporting and data system. CAD-RADS is categorized into 0 to 5 categories based on percentage of the stenosis caused by the coronary plaques. Here we can see there is no plaque and there is no stenosis. There is no plaque, there is no stenosis. It is called as normal coronary arteries. It is categorized as CAD-RADS 0. The plaque causing minimal stenosis of less than 24% is called as minimal non-obstructive coronary artery disease. It is categorized under CAD-RADS 1. When the plaque causing stenosis of 25 to 49% causing mild stenosis, then it is interpreted as mild non-obstructive coronary artery disease. It is categorized as CAD-RADS 2. When the soft plaque causing stenosis of 50 to 70%, then it is interpreted as moderate stenosis, and it is categorized under CAD-RADS 3. The CAD-RADS 4 is further divided into CAD-RADS A, CAD-RADS 4A, CAD-RADS 4B. The CAD-RADS 4A is when the plaque causing 70 to 99% of the stenosis in 1 or 2 vessels. And CAD-RADS 4B is plaque causing more than 50% of the stenosis in the left main or 70% of the stenosis in 3 vessels. Then it is called as CAD-RADS 4B. This is interpreted as severe coronary artery disease, and CAD-RADS 5 is there is total occlusion of the coronary artery by the plaque, then it is called as total occlusion. It is categorized under CAD-RAD 5, and CAD-RAD N is non-diagnostic study. When there is stepping artifacts or movement artifacts due to respiration, we can't evaluate the coronary arteries, and we cannot comment on coronary artery disease. Then it is categorized as non-diagnostic study, and it is categorized as CAD-RADS N. From CAD-RADS 0, 1 and 2 categories, there is no further evaluation is required. For CAD-RAD 3, we will advise to undergo functional assessment. Then CAD-RADS 4A, patients with CAD-RADS 4A, we will advise functional assessment or invasive coronary angiography for further evaluation based on the patient's condition and stability of the patient. And CAD-RADS 4B patients, we will advise invasive coronary angiography. And CAD-RADS 5 for total occlusion, we will advise invasive coronary angiography or viability assessment based on the patient's condition. For CAD-RADS N, we will advise additional evaluation to diagnose coronary artery disease. Thank you. In my next video, I will show one normal CT coronary angiography and one patient with coronary artery stenosis, which we have done in our institute. Thank you.